Assalamu alaikum. Can you hear me?
Yes. Assalamu alaikum, sir.
Wa alaikum assalam.
Ji, okay. Assalamu alaikum. I'm Dr. Saad from Khan University Hospital. So, on behalf of PSA, it's my pleasure to welcome you all to the PSA online lecture series on cardiothoracic anesthesia. So, we will start from today and it's continue through the July 2026. So, basically, this academic initiative basically it comprises of 12 structured online lectures, which focused on the evidence-based practices and recent guidelines related to anesthesia, intensive care, and pain management. So basically, it's the first lecture of this series, and the topic of today's presentation is applied physiology for the anesthetist, and which is particularly related to cardiovascular system. So it's an honor to me to welcome our esteemed speaker, Dr. Rashad Siddiqi. He's a professor of anesthesiology at Army Medical College, Rawalpindi, and consultant cardiac anesthetist at the Armed Force Institute of Cardiology, National Institute of Heart Diseases, Rawalpindi. So we are grateful to him for joining us today and sharing his expertise. So before we start the presentation, I would like to request from the participant to please keep your microphones be muted and switch off the videos during the lecture. And any questions, you can post it into the chat box either during the lecture or at the end. And most importantly, after the completion, please fill the feedback form which is required to obtain your e-certificate. So over to you, Dr. Ashad, please.
Thank you so much, Dr. Saad, and I'm really thankful to the organizers of this lecture series. And this is my first experience to be part of this August forum. As you have mentioned, this is a series of cardiothoracic anesthesia. I was initially given the topic of applied physiology for the anesthetists, including cardiovascular, respiratory, and neurological system. But I could not do justice to all the three systems. So, keeping in view the lecture series was on cardiovascular system, so I'll try to keep it restricted to cardiovascular system, and I will try to cover the respiratory system in another lecture, either live online, or I will try to record a lecture for you and share with Dr. Saad, and maybe he'll be able to upload it on the YouTube channel. The problem is that I'm struggling with my MacBook and I'm unable to take away these. I don't know. Let's see. Okay. So just hold on. Sorry. Can you stop sharing my screen for a while, the admin? Can you do that? Can the admin stop sharing my screen? Okay, thank you. So we all know that heart has its own chambers and valves. We have specialized self-excitatory striated muscles that comprise of the myocardium. And the myocardium is composed of serial low resistance intercellular connections, which are called intercalated discs. These connections allow rapid spread between the current between the atria. And there is no direct connection between the atria and the ventricle, and the flow of current is actually dependent on specialized conduction pathway, and those specialized conduction pathway go through the atrioventricular nodes, as we call them AV nodes, that are causing a delay in the conduction. And these specialized conduction is basically play a very vital role in the function of the heart. So we are all familiar with the cardiac action potential and the skeletal muscle action potential. On the left side, you can see the action potential of the skeletal muscle. Typically, there is a depolarization phase and a repolarization phase. But on the right side, if you see, there is a plateau phase in the cardiac action potential. So the cardiac action potential is typically seen having four phases. The phase zero, also known as the upstroke phase, is caused by an activation of the voltage-gated sodium channels. They open up, and there is influx of sodium inside the cell membrane, across the cell membrane. And that is followed by inactivation of those sodium channels, and there is a transient increase in potassium permeability. So there is an early rapid repolarization, followed by a plateau phase. This plateau phase is not seen in skeletal muscles, and this is caused by an activation of slow calcium channels. So if you see, there's a phase two caused by the slow calcium channels, plateau phase. And then there is a final repolarization phase because it is caused by inactivation of calcium channels, and there is increased permeability of potassium. And then there is a resting potential phase, that is phase four. And sorry, now it's working. So, and then there's a resting potential. This is phase four, which is caused by intrinsic, there's normal permeability of restored atrial and ventricular cells, and intrinsic slow leakage of calcium into the cells, that spontaneous depolarization. And on the right side is the typical cardiac action potential of the myocardium. But on the left side, this is the action potential of the sinoatrial node fiber. So this is different. We see that the resting action potential is a bit less negative as compared to the myocardium. So we go to the sinoatrial node. What is sinoatrial node? Sinoatrial node is basically the pacemaker of the heart. It is placed in the sulcus terminalis at the junction of SVC and RA. And there is a slow influx of sodium through hyperpolarization cyclic nucleotide gates, HCN channels. And the resting membrane potential is less negative as compared to the rest of the myocardium, that's around minus 50 to 60. And when this sodium channels, leaky sodium channels, reach a threshold of minus 40, there is spontaneous depolarization. And the impulse spreads rapidly to the atria. See, we discussed earlier that because of the intercalated disc, the spread of the current is very rapid. And within 0.04 seconds, the SA node throughout the atria, the current is spread. But when it reaches the AV node, there is a 0.11 to 0.18 second delay. And because there are slow conducting fibers dependent on the L-type calcium channels in the AV node. Then after the AV node, the His-Purkinje system is present in the interventricular septum and the ventricular muscle fibers. And this is the fastest conducting system. And within 0.02 to 0.03 second, the whole ventricular walls are, the current is conducted throughout the whole ventricular walls. So what are the effect of anesthetics on the conduction of the conduction system of the heart? So most anesthetics depress the SN node automaticity. So the SN node, which is the natural pacemaker of the heart, is depressed by the anesthetics. And there is a modest direct effect on the AV node as well, causing prolonged conduction time and increasing the refractoriness of the AV node. So this combination of effect causes junctional tachycardia when an anticholinergic is administered for a sinus bradycardia during inhalation anesthesia. So what is happening is that the SA node is depressed more as compared to the AV node. So if a pure inhalational anesthetic is used, the theory is that when you use atropine for the sinus bradycardia, it will affect more on AV node, and the heart rate will increase uh, from the AV node more. So we will see a junctional tachycardia in response to the atropine as compared to sinus tachycardia. So junctional pacemakers are accelerated more than those in the SA node. The effect of anesthetics is a bit complex on the Purkinje fiber system, ventricular muscles due to autonomic interactions there, because we'll go through the autonomic innervations a bit more in detail in the future slides. So there is an antiarrhythmic effect of anesthetics because of the direct depression of the calcium influx in the Purkinje system and ventricular muscle fibers. But there is also arrhythmogenic properties due to potentiation of catecholamines, especially with the previously used halothane in the as a volatile anesthetic. Opioids, fentanyl, sufentanil, they depress cardiac conduction. They increase the AV node conduction time, just like the volatile anesthetics. They increase the refractory period, and they prolong the duration of the Purkinje fiber action potential. So the effect of anesthetics on the conduction system are mostly on depressing side. The local anesthetics, they bind open or inactivated sodium channels. So lignocaine at low blood concentrations can be therapeutic. So we all know that lignocaine is used as an antiarrhythmic as well. But at high blood concentrations, local anesthetics can depress conduction. And at extremely high concentration, they also depress the SA node. On the other hand, the bupivacaine, which is considered more cardiotoxic, it dissociates from the sodium channels more slowly. Therefore, it causes sinus bradycardia more profoundly, and it can cause sinus node arrest. Bupivacaine is also known to be causing malignant ventricular arrhythmias and depress the left ventricular contractility. So the local anesthetics, they can be uh, you know, therapeutic as well as toxic. So the next step is myocardial contraction. So how does the myocardial contraction occurs? The myocardial contraction occurs through the interaction of overlapping proteins, which is actin and myosin. The actin and myosin proteins, the calcium binds with troponin C, so exposing the active bridges site, that is bridging sites on the actin and myosin. And in this process, ATP is consumed. Uh, for this process, high quantity of calcium is required. And for this, calcium-dependent calcium release is required. And the thing is that for myocardial relaxation, calcium is again actively pumped back into the cytoplasmic reticulum, requiring the calcium, magnesium, ATPase. So the myocardial relaxation is also an active process. It's not a passive process, and it is also requiring calcium, magnesium, ATPase. So this is a diagrammatic representation on the left side. I'm sorry, the cursor mouse is not working here. So if you see on the left side, you can see that it is the excitation phase, and on the right side is the recovery phase. So if you see on the left side, you can see that the calcium is released from the sarcoplasmic reticulum, and this release of calcium is causing calcium-dependent calcium from the T tubules. So this calcium-related calcium release is actually causing uh, the actin and myosin moving together. And then on the right side, if you see, the ATPase is using for the relaxation time. So the myocardial contraction is actually dependent on multiple factors: the quantity of intracellular calcium available, and it will actually result in the maximum tension developed. The rate of the delivery, which will result in the rate of contraction, and the rate of removal, which will determine the rate of relaxation. So the myocardial contraction is actually dependent on the calcium available, the rate of delivery, and the rate of removal, how fast the calcium is released from it is reuptaken in the sarcoplasmic reticulum. So what are the effects of drugs on this contraction? How the different drugs actually work? So we know that we use norepinephrine and epinephrine and digitalis. The beta-1 agonist actually increase the intracellular cyclic AMP. That actually how this work? It recruits additional open calcium channels. What does the phosphodiesterase inhibitors do? The phosphodiesterase inhibitors prevent the breakdown of intracellular cyclic AMP. So the intracellular cyclic AMP breakdown is decreased, so it is available for more calcium channels. Milrinone, in addition, activates the phosphokinase A, improving the calcium reuptake. So it has a lucitropic effect as well. Lucitropic effect is actually helping the heart diastolic function. It's a digoxin, the digitalis the group of drugs. They inhibit the sodium potassium ATPase. So they actually increase the calcium in the sarcoplasmic reticulum. Glucagon increases the intracellular cyclic AMP via activation of a specific receptor. Levosimendan binds to troponin C. It acts as it functions it helps in contraction. And then do the newer drugs, omecactive, mecabril, and estraxamine have activated the myosin activator, increases cardiac muscle contractility duration. And the etraxamine has both inotropic and lucitropic effects, improving both systolic and diastolic functions. So the newer two drugs I have never used, levosimendan, we have already read about it. So the other effects of on the heart is the release of acetylcholine following vagal stimulation. What that happens is when there's a vagal stimulation, there is increase in cyclic GMP levels. There is inhibition of adenylyl cyclase and depressed contractility. As well as when there is acidosis, there is inhibition of L type of calcium channels. So vagal stimulation as well as acidosis, they decrease the contractility of the heart. So we are talking about the contraction, myocardial contraction, and these myocardial contraction, it is increased by acidosis, vagal stimulation as well. So volatile anesthetics depress the cardiac contractility. How do they do it? They decrease the calcium entry during the depolarization. They affect both the T and L type channels. They alter the kinetics of calcium release as well as the calcium reuptake, and they decrease the sensitivity of contractile proteins to calcium. And this cardiac repression is potentiated by if there is, ongoing hypocalcemia, there is beta adrenergic blockade. If the patient is on calcium channel blockers, this cardiac depression is increased. In the early diastolic relaxation, there is minimal effect. And in decreased atrial function, there is reduced late diastolic filling. Nitrous oxide has a concentration-dependent decrease in contractility by reducing the availability of intracellular calcium during contraction. Intravenous anesthetics also cause decrease in the contractility, but the cause of the effect is not well established, and it is presumed that it is caused by the similar actions as of the volatile anesthetics. In all the IV anesthetics, the ketamine has the least depressant effect on the contractility of the heart. Rather, it has more of the sympathomimetic effects, causing increase in contractility and chronotropy of the heart. The heart is innervated by both sympathetic and parasympathetic nerves, autonomic innervation. Parasympathetic fibers innervate the atria and the conducting tissue. So acetylcholine acts on the muscarinic type 2 receptors on the heart. The onset is rapid and resolution is also rapid. Whereas the sympathetic fibers, they are widely distributed throughout the heart. And the sympathetic nerves, they originate from thoracic 1 to thoracic 4 vertebrae through the cervical stellate ganglion, and they innervate the heart from the cardiac nerve. They primarily act through the beta 1 and beta 2 adrenergic receptors. And the onset is gradual and the dissipation is as well as gradual. So as we were discussing, that the sympathetic innervation is more on the it's distributed throughout the heart, whereas the parasympathetic innervation is mainly on the atria and the conducting tissue. So the next is after this discussion of the conducting the conduction of the heart and the innervation of the heart. The next is the cardiac output and cardiac index. So basically, the actually the functioning of the heart. So ventricular function is actually equated with the cardiac output. And what is cardiac output? The cardiac output is the volume of blood pumped out of the heart per minute, and it is expressed as liters per minute. We are all familiar with this equation. Cardiac output is equal to the stroke volume into heart rate, whereas stroke volume is multiplied by heart rate. It is normally 5 liters per minute, but it varies with metabolic level, activity, age, and size. Cardiac index is the term when the cardiac output is corrected for size only using the body surface area, and it is calculated as cardiac index is equal to cardiac output divided by body surface area, and it is roughly 2.5 to 4.2 liters per minute per meter squares. So where the whole blood flow goes, the cardiac output we see, I don't know why these lines are coming on my screen from where, I don't know. So the cardiac output is actually from the right heart and the left heart is practically equal. So it cannot be like the left heart is pushing out more blood and the right heart is not. It is equal. But the blood from the right heart is all going to the lungs. But from the blood from the left heart is actually going from the aorta to different parts of the body. 14% to the brain, 4% to the heart, 27% to the splanchnic circulation, 22% to the kidneys, 15% to the muscles, and 18% to the skin and the tissues. And this cardiac output, we will be discussing this cardiac output or this systemic circulation is controlled by different factors that we'll be discussing in the next few slides. So the cardiac index has a wide range. So we said it's 2.5 to 4.2 liters per minute per meter square. So is it good? No, it's not, because it's wide. It is insensitive measurement. So what could be more accurate? Something that responds of cardiac output to the exercise, something that keeps up with the oxygen consumption. So what it could be that what we have found that decreased venous oxygen saturation corresponds with decreased perfusion, and mixed venous oxygen saturation has been found in absence of anemia and hypoxemia. Mixed venous oxygen saturation has been found that it corresponds with the cardiac output. So in the clinical settings, if a patient does not have anemia or hypoxemia, if he or she is in a low cardiac output state, what happens is that there's low perfusion, so there is more oxygen extraction, and the mixed venous oxygen saturation is low. So it is more accurate as compared to cardiac index. Now, mixed intravenous oxygen saturation is where it is taken from uh, the pulmonary artery, because the oxygen extraction is more from the upper part of the body, that is in the SVC, and it is less in the lower part of the body from the IVC. So the mixed venous is called mixed venous because it is taken from the pulmonary artery when the IVC and SVC blood is mixed in the right ventricle, and we take the sample from the pulmonary artery. So this sample is only possible through a Swan-Ganz catheter. It is more invasive, and it is a more invasive and not a routinely done procedure. So a surrogate to mixed venous oxygen saturation is central venous oxygen saturation. So mixed venous is written as SVO2, and central venous is written as SCVO2. And then there have been multiple studies that tell us that SCVO2, yeah, that is central venous oxygen saturation, can be used as a surrogate to see the patient's cardiac output state instead of mixed venous oxygen saturation, right? As a trend. So, what are the determinants of the cardiac output or the ventricular function? So, the cardiac output is ventricular function. So, we know that cardiac output is dependent on heart rate and stroke volume. And for the heart rate, we talked about the conduction of the heart and the factors that affect the heart rate, and all the anesthetic factors that could affect the heart rate. So the next thing that we'll be discussing is the stroke volume and what factors affect the stroke volume. So there is preload, there is afterload, there is contractility, there are wall motion abnormalities, and there is valvular dysfunction. So let's take preload first. So what is preload? So preload is basically left ventricular and diastolic volume. So whenever you are using preload, the preload is actually preload of the heart, and it is both for the right ventricle and the left ventricle. But when we say left ventricular and diastolic volume, because actually we are more concerned about the left ventricle. So if you see this diagram, I don't know why these yellow lines appearing on this slide. Okay, so if you see the diagram on the right side, there are some curves, the purple color curves. So the second curve from the top is normal curve. So this is Frank-Starling curve. So the Frank-Starling curve is that there's the on the x-axis there is ventricular and diastolic volume, and on the y-axis there is cardiac output, right? So this curve tries to tell us that when the end diastolic volume increases, the cardiac output increases, but to a certain state. So it is not a linear relation. So there is a maximum time, there is a maximum stage from till when the heart can fill. So this Frank-Starling curve has its own limitations. So the heart, and for a normal heart, for a failing heart, this curve goes down. So a little volume and the cardiac output will go down. So a failing heart does not take volume very well. So that is the whole science. So the failing heart does not take volume very well. So this we need to understand. So cardiac output increases with increased preload until excessive end diastolic volume is reached. This is a Starling law. So what are the perioperative effects on preload? So what things actually affect the preload? So we all know the blood volume. So excessive blood loss, the preload is decreased. Excessive preloading of the heart of the patient. We are putting a lot of volume to the patient before spinal anesthesia or before epidural anesthesia. We are putting a lot of preload. So we are putting a lot of volume to the patient. We are increasing the preload. So patient's blood volume is preloads, right? So, and then second thing is the distribution of blood volume. So how that volume is distributed. What will be the posture during the surgery? Will the patient will be in supine position? Will he or she be in reverse Trendelenburg position, or she will be in Trendelenburg position? So that is going to affect the preload. Then intrathoracic pressure changes, like the positive pressure ventilation during anesthesia is going to decrease the preload. Then the pericardial pressures in pericardial diseases, if the patient has some tumor, or if the patient has pericardial, severe pericarditis, restrictive pericarditis, constrictive pericarditis, or if the patient, the surgeon is doing some thoracic or mediastinal surgery, so this could affect our preload. Then the venous return could decrease because of the mass in the abdomen or pregnancy. We are so these things, actually the distribution of blood volume can affect the preload. Then the rhythm of the heart has a major effect, and this 30% of the preload in the ventricular preload is given by the atrial contraction, and this atrial contraction is lost in atrial fibrillation. So a normal sinus rhythm is important in maintaining a good preload. And a heart rate, a very fast heart rate is also known to decrease the preload, because in tachycardia, the diastolic time is proportionately decreased more than the systolic time. And the diastolic time is the filling time of the heart. And that during that time, the heart is actually not filled up, the preload is decreased. So these are the perioperative effect that can cause changes in the preload. So is LV end-diastolic pressure, the LV is equal to the LV end-diastolic volume? So, or can we say LV end-diastolic volume represented by LV end-diastolic pressure? So no, it's not true, because again, the volume and pressure, they are not linear, and the reason is something called compliance. So again, if you look at the graph on the right side, there is the x-axis is the end-diastolic volume, and but on right about this time on the y-axis, there's a ventricular end-diastolic pressure. So when the end-diastolic volume increases, the end-diastolic pressure initially does not increase so much until a time reaches that the heart is initially compliant. It is taking volume and it is not increasing the pressure a lot. But at one time, it then afterwards, when it is filled up, it is increased. So if the pressure is not increasing much, we say the heart is not very, it's more compliant. If the pressure is increasing a lot, so it is less compliant. So at the same volume, a less compliant heart would have more LVEDP, but have less LVED volume. So left ventricular end diastolic volume is not equal to the pressure. And this is because of the decreased compliance. So decreased compliance basically is caused by the impaired diastolic function. So the diastolic function is basically when the heart is unable to relax. And the decreased diastolic compliance can be early diastolic compliance decrease or late diastolic compliance decrease. The early diastolic compliance decrease is because of the rate of relaxation is not good, and it's typically seen in hypertrophy associated with hypertension and aortic stenosis, and it's seen in ischemia and asynchrony. Whereas the late diastolic compliance decrease is seen in patients with fibrosis, hypertrophy, and in cases of extrinsic factors, where like for example, pericardial diseases or surgical compressions. So we need to understand that this diastolic dysfunction, which we'll be discussing in future slides, it causes decrease in compliance. So this decrease in compliance is actually the reason that why the left ventricular end diastolic pressure is not always tells us about the left ventricular end diastolic volume. My slide has stuck. Can somebody hear me? Hello?
We can hear you, sir.
Yes, Dr. Rashid, we can hear you. You're audible.
अच्छा लेकिन मेरी slide I can't move my slide. I don't know why.
Slide is also visible, but it's not moving.
Yeah,
Like it's static now.
yeah, it's static.
सर एक दफा बैक करके फॉरवर्ड करके देखिए.
Yeah, but sometimes not working.
Dr. Sadia, will you please check this?
Uh,
Dr. Rashad, I can't hear you. Can you please come again?
yes, okay, it's working now. Thank you. Right. So we have discussed about the preload. Now we come to the next part that of the ventricular function is afterload. Right. So the afterload is actually the pressure the ventricle must overcome to eject blood. And it is usually measured as the systemic vascular resistance or the pulmonary vascular resistance for the right heart. And systemic vascular resistance is calculated as mean arterial pressure minus the central venous pressure divided by cardiac output and multiplied by 80. And it is calculated, is measured 900 to 1500 dynes to seconds per centimeters raised to the power 5. And it is 50 to 150 for pulmonary vascular resistance. And for the pulmonary vascular resistance, the LA pressure is actually, we are unable to take it. So the pulmonary capillary wedge pressure is considered as LA pressure. So what are the anesthetic effects on the afterload? The anesthetics, they all decrease the SVR. Volatile anesthetics as well as intravenous anesthetic. They cause decrease in the systemic vascular resistance with two factors like due to their effects. One is vasodilatation and the other is decreased sympathetic tone. The vasodilatation is caused by vascular smooth muscle relaxation, calcium modulation, and their effect on the alpha 2 receptors on the vasculature. Whereas the decreased sympathetic tone is through the action on GABA receptors, depressing the excitatory neurotransmitter, and attenuating the baroreceptor reflexes in the autonomic system of the cardiovascular, this circulatory system. Then coming to the contractility. So the third factor that affect the stroke volume and ultimately the ventricular function of the heart is the contractility. So the contractility is actually the intrinsic ability of the myocardium to pump in the absence of change in preload or afterload. So if the preload and afterload is considered to be static, so it is the intrinsic activity. And it is related to the rate of myocardial shortening and the intracellular calcium concentration. It is increased by sympathetic stimulation, and this sympathetic stimulation is actually more prominent through the beta 1 receptors activation. And these beta 1 receptors are present in the heart primarily, and they cause both the chronotropic effect as well as the inotropic effect. There are minor activation of alpha receptors in the heart, sorry, and the the receptor effects are more actually overwhelmed in the vessels rather than the heart. So the contractility is basically more through the beta 1 activity. And the contractility is depressed by hypoxia. It is depressed by acidosis. It is depressed by the depletion of catecholamine stores within the heart and its loss of functioning of muscle mass, like because of ischemia or infarction. So we all discussed earlier how the muscle, the myocardial contractility is affected by all these effects. And most anesthetics and antiarrhythmic agents, they are also negative inotropes. Then the next thing that affects the cardiac output and cardiac index or the ventricular function is the wall motion abnormality. The regional wall motion abnormality, RWMA, that we usually call, is when a region of the heart does not contract in a synchronized fashion. So what happens is the ventricular cavity does not collapse symmetrically, and so the emptying of that area is impaired. And it happens due to ischemia, scarring, hypertrophy, or altered conduction, right? So that part of the heart is not emptied completely. And the regional wall motion abnormalities are divided into three different kinds. Like it could be hypokinesis, when there is contraction is decreased, the motion is decreased. It could be akinesis, whereas the contraction is absent. There is no motion at all. Or the worst, could be dyskinesia, when there's the bulging or there is a paradoxical movement of that part of the myocardium. And the anesthetics that we use, they can actually induce or they could worsen the regional wall motion abnormality. And they do it by the myocardial depression. They can do it by vasodilatation or by hypotension. And with hypotension, they actually they cause coronary ischemia and the sevoflurane is being considered as myocardial protective. It has been known to be, useful for patients sort of stunned myocardium, and it has been used with prophylactic norepinephrine for patients for regional wall motion abnormality, and it is being considered. Isoflurane was once about 2 decades ago, or more than that, or almost 3 decades ago. It was very notorious for coronary steal syndrome, but later on it was found out to be a false alarm, and it's no more considered to be causing that problem. But sevoflurane these days is considered to be very myocardial protective drug. Then coming to the valvular dysfunctions, the valvular dysfunction actually contribute a lot to the ventricular function, and the stenotic lesions, they decrease the cardiac output. So in the atrioventricular valves, like in the mitral and the tricuspid valve, the stroke volume is decreased because of the decreased preload. But in the semilunar valve, in the pulmonary valve, or in the aortic valve, the stroke volume is decreased by the increased afterload. So the afterload is increased, and therefore the cardiac output or the stroke volume is reduced. But on the other hand, in the regurgitant lesions, the stroke volume is decreased without the changes in the preload, afterload, contractility, or regional wall motion abnormality. It is actually the effective stroke volume is reduced by the regurgitant volume. So the volume is actually going back, and it is different in both the AV valve diseases and the semilunar valve disease. In the AV valve diseases, the significant part that the ventricular and diastolic volume can flow backward into the atrium. So from the left ventricle, when the LV is contracting, the forward flow to the aorta is actually reduced, and a part of the blood is going back into the left atrium through the regurgitant mitral valve. So the ejection fraction is not it is reduced, but in the case of the semilunar valves like aortic valve and pulmonary valve, the end diastolic volume is sent back. So it is ejected forward, but it is sent back. So in both the cases, the stroke volume or the cardiac output is reduced. So in stenotic lesions, the cause is different. In the valvular lesion, in the regurgitant lesions, the cause is different. So the next thing is, how do we assess the ventricular functions? It is a very wide topic. I'll just try to touch it. I cannot do justice to this topic, but just to touch the basic applied physiology of assessment of ventricular functions. I'll just try to touch it very shortly. So ejection fraction. We talked about ejection fraction a lot. It's a fraction of blood volume ejected from the ventricular chamber during systole. So it is a common measure of systolic function. And ejection fraction is end diastolic volume minus end systolic volume divided by end diastolic volume. And the normal ejection fraction is 50 to 75%. And this is एक slide बीच में गायब हो गई, sorry. So this is a volume pressure diagram. I'll try to explain it without marker. So if you see this on the x-axis, there is a left ventricular volume, and on the right axis, on the x-axis, y-axis, is left ventricular pressure. So this is similar volume, but now it is more detailed. So from point A to point B, there is the mitral valve is opening, and there is a flow of blood into the left ventricle. So you see there is a flow of blood in the left ventricle from point A to point B. There is no increase into the in the pressure. From 50 to 110, the volume is increasing. But if you see, there is a slight bump in just before the B. So what this bump signifies, this is probably because of the atrial kick. So the left atrium contracted, and there was an increase in the volume as well as left ventricular pressures. And then the mitral valve closes at point B. So at point B, this is end diastolic volume. At this end diastolic volume, the left ventricle starts contracting. And there is from point B to point C, there is also isovolumetric contraction. So there is contraction, there is an increase in the pressure, but there is no ejection of the volume because the aortic valve is closed until we reach point C, where the aortic valve opens. Now, from point C to point D, there is period of ejection. There is initial an increase in the pressures, but there is a decrease in the volume of the left ventricle. And from point C to point D, we see there is a decrease in the volume. And at point D, the aortic valve closes, and there is a rapid decrease in the left ventricular pressure back to the point A. So this is one cycle of LV contraction. And the stroke volume is between these two lines, from the isovolumic contraction to isovolumetric relaxation. And the whole shaded area is actually the work that the heart has to do. So this is the work the heart has to do, right? So this is and this point D is the end systolic point. And in the next 2-3 slides, I'll try to explain that the end systolic point actually remains same, and the end systolic point, if the heart's contractility is not changed. So if the preload and afterload are changing, so the end systolic point remains in the same point. So the relation remains the same. So I'll try to explain it to you. So this is the end systolic point, and this is the end diastolic point, right? So the relation remains linear, right? So this is what I was trying to say. Okay, so what happens, right? So in this on the slide, there are 3 curves. There is a red curve, there is a green curve, and in between there is a gray curve. In the gray curve, it is the control. This is the normal, right? So this is the normal curve that we have seen, right? So, but let's say the patient has high preload. So normally doesn't happen, right? Normally the body works in there's a lot of things going on, the preload and afterload and heart rate and everything. But so let's just assume that only the preload is changing. So if the preload is changing, so the heart keeps on receiving the blood, and when the preload is increased, then the mitral valve closes and the end diastolic point goes further on the right. So the end diastolic point goes further to the right, and then the isometric contraction goes up and the heart starts contracting. And but you see, the end systolic point remains the same on the same dotted line, that is going diagonal on the left side. It goes and touches that, and it comes down. So if the area of the shaded area of the gray and if the shaded area of the red, you see, so with the increased preload, the heart has actually worked more. The heart has worked more than the control. So the shaded area was in the gray was smaller, but the shaded area of the red was more. Similarly, if the preload was less, right? So the heart was filled, the end diastolic point was reached earlier, the mitral valve was closed, the isometric volumetric contraction, and because the contractility was not changed, the end systolic point was reached at the same point, and there was contraction and there was closure of the aortic valve, and it came down. And the work done, the green is, now you can see it is smaller. So the work done by the heart is smaller. So when the preload is increased, there is more blood returning to the heart, ventricle stretches and is able to eject more blood. So increased stroke volume without requiring increased pressure. So the pressures were not increased, the conductivity was not increased, but there was more blood and cardiac output was increased. What happened to when the heart afterload was increased? So the afterload was increased. So say again, the gray one is the control. So when the afterload was increased, what happened was that the end diastolic pressure was same, right? The end diastolic point was same, the volume was same, but the afterload was increased. So the isovolumetric contraction went more up, but the contractility of the heart was same. So the end systolic point it came to the same dotted line. Actually, it came to the same dotted line and it went down, and it came down earlier than the one. And so the ventricle had to generate higher pressure, and the volume that ejected the heart, that left the heart, was less than what was. So the end systolic volume at the end was more than the normal one. So because of the increased afterload, the end systolic volume was more. So ejection fraction was lower. So, but if you see the ESV ESP ratio, the end systolic volume, the end systolic point ratio, the relation was preserved. So this is also called ESV PR. This dotted line, it was preserved. It was the same linear line. But this is the third scenario. This is where the inotropy was increased. So when the inotropy was increased in the red line, so you see that the ventricle generated higher pressures and ejected more volume, and that dotted line, the end systolic point, actually moved to the left. When it moved to the left, the end systolic volume was lower, and the ejection fraction was higher, and the end systolic point volume relation was, the slope was more steep. So this was the difference. So this is the point that I wanted to try to tell you, that this is something if we try to understand. So when the contractility is increased, the ESPVR slope becomes steeper. So ejection fraction is usually measured with echocardiography. It could be transthoracic echo, it could be esophageal echo. It is measured by catheterization, radionuclide studies. It could be used thermodilation technique using PA catheters, or cardiac motion quantifications that measures strain or torsion through MRI or echo. This is a typical PA catheter. We are all familiar with that. There is a balloon inflated for PA capillary wedge pressures if you are required. If you're not, so there's a thermistor port and there's a distal port and there is a proximal port and there is a syringe. There is thermistor connection. And there is a proximal infusion line and distal infusion line, and this is used for thermal elution technique. So diastolic dysfunction is assessed by Doppler echo, transthoracic echo or transesophageal echo, and the flow velocities across the mitral valve during diastole they are measured. And if you can see, so now, so the Doppler flow velocities across the mitral valve, they are measured on echo, and we see the two distinct these waveforms. There is an E wave and there is an A wave. The E wave is peak early diastolic flow, and the A wave is basically peak atrial systolic flow. So what is early diastolic flow is but when the mitral valve opens and there is a flow of blood before the atrial contraction, and then the A is when the atrial contraction. So this is normal EA ratio, that is 0.8 to 1.2. So E is bigger than the A. What happens is when the ventricle is having impaired relaxation, the EA ratio is inversed. So the EA ratio is less than 0.8, and you can see that in picture B, the E is smaller than the A. In further worsening of the case, when the ventricle become further stiff, there is a pseudo normalization, and the E becomes again becomes high. So it looks like normal, but it is further high, and we need to check it with tissue Doppler on esophageal echo. And then it could be in restricted cases, it could be EA ratio. So they are different. It's a totally it's a very detailed topic, and I'm sure we'll having topics on echocardiography, and Dr. Rehan or Dr. Fakhr will be discussing it with you in detail. So I just wanted to give you a touch of diastolic dysfunction. So quickly about the systemic circulation. Systemic circulation is divided into arteries, arterioles, capillaries, and veins. 7% in the heart, 9% in pulmonary circulation, 15 arteries, 5% capillaries, and 64% of the circulation is in the veins. And this is something very important because the venous pooling basically gives us reservoir for patients for our requirements whenever there is requirement of blood. There is sympathetic tone that allows this recruitment of blood from this venous pool. What are the factors that influence blood flow? There are metabolic products, that autoregulation, then endothelium-derived factors, autonomic nervous system, and circulatory hormones. So most tissues beds regulate their own blood flow. The arterioles dilate in response to perfusion pressures or increased tissue demands. And when there is increased pressure or reduced tissue demands, like intrinsic response to vascular smooth muscles to stretch, or there are vasodilatory metabolic byproducts like potassium, hydrogen ion, carbon dioxide, adenosine, or lactate. So there is a vasodilatory metabolic byproducts that causes vasodilatation of the arterioles. Then there are endothelium-derived factors like vasodilators, nitric oxide, prostacyclins, vasoconstrictors, anticoagulants, fibrinolytics, circulatory hormones. Then we discussed about autonomic control of the vasculature. They are primarily sympathetic. So these sympathetic control of the vessels is mostly from the thoracic segments and the first two lumbar segments. They innervate all parts of the vessels except the capillaries, and its primary function is to regulate the vascular tone. They serve to regulate the blood pressure and distribute blood flow to the various organs. and the variations in venous tone alter vascular capacity, venous pooling, and venous return to the heart. Sympathetic induced vasoconstriction, which is mainly via the alpha-1 receptors, is potent in skeletal muscles, kidneys, gut, and skin, but it is least active in the brain and heart. Vasodilatory fibers are those feeding the skeletal muscles, mediating increased blood flow via the beta 2 agonist in response to exercise.
Dr.
Dr.
Rashad, sorry to disturb you.
Sorry.
Basically, time is up. Can we start question and answer, if you allow?
Okay. So
पता नहीं भाई
I was not able to even complete the cardiovascular system.
Yeah, sir.
Sir,
So
we can give you 5 more minutes so you can quickly wind up, and we'll then take the question session.
Okay, like just 3-4 slides more. I tried to.
Thank you,
So
sir.
they're just about coronary circulation, and we all know about the coronary circulation, about the anatomy. Okay, I think we can skip that. We can. If there are any questions, I'm happy to answer those. Please. I hope there are no more questions because I'm very bad at physiology.
yes, please. Any questions you can ask or any comment?
I think there were some comments in the comment section.
So, sir, there is nothing to ask in the chat box. So, anyone, if any question, we can ask from Dr. Rashad, or any comment you can add. So, thank you so much, Dr. Rashad, for delivering an excellent lecture for understanding the cardiovascular responses to anesthesia, surgery, and critical care illnesses. So basically, it's understanding the physiology is basically to treat the cause, not to monitor.
Doctor.
So, any
Thank you
questions or
so
any
much, Dr.
comments?
Rashad. I would like to just add a few comments, and it was really insightful and captivating. We really, it was a short time. 1 hour is really short, and we cannot do justice to the topic. But you have explained everything very clearly. Thank you, sir.
Thank you
And
so
Dr. Saad, I also welcome you.
thank you so much. Thank you so much for giving this opportunity, and I hope I made justice to the topic. And it's a relatively dry topic, and I try to make it as palatable as possible.
Yeah. Thank you so much, Dr. Rashad. Thank
Thank
you
you.
for an excellent talk, sir. So I
Thank you.
would also thank to all the participants for joining us online. So please fill out the feedback form which is required to obtain e-certificate. Thank you so much, and we'll meet inshallah in the next lecture. Thank you
Thank you
so
so much.
much.
Allah Hafiz.
Thank you. Allah Hafiz.